You are walking across your own living room, flat floor, nothing in the way, good lighting, and your body drifts, not a trip, not a stumble over anything, just a loss of the straight line. A moment where your legs and your sense of direction stop agreeing with each other. If that has happened to you, your doctor probably told you to strengthen your legs, maybe suggested a cane, maybe checked your blood pressure. And nothing changed, because the problem was never in your legs. It was never in your feet. It is in your brain, and specifically in how much blood is reaching one precise part of it. I'm Dr. Chandler. I study the physiological changes that accumulate in the aging brain and body after 60 the ones that conventional medicine tends to label as normal aging rather than addressable mechanisms. Research published in the journal Stroke has documented that vertebrobasilar insufficiency, reduced blood flow to the back of the brain, is significantly more prevalent in adults over 60 and is directly associated with balance disruption, dizziness, and cognitive slowing. By the end of this video, I will show you the exact daily protocol that addresses the mechanical source of this blood flow reduction. And it starts somewhere most people would never think to look. Here is what concerns me most. When someone starts drifting, when they walk or feels dizzy standing up, the instinct is to slow down, to avoid stairs, to stop going out alone. And I understand that instinct completely. But here is what actually happens when you do that. Movement is one of the primary drivers of blood flow to the brain. The less you move, the less circulation reaches the cerebellum. The less circulation reaches the cerebellum, the worse the coordination gets. You avoid movement because of the symptom, and the avoidance worsens the cause. It is a spiral, and the longer it runs, the harder it is to reverse. But it is reversible. That is what I need you to hold on to. At the base of your skull, tucked underneath the larger cerebral hemispheres, sits a structure called the cerebellum. By volume, it represents only about 10% of your total brain mass. But here is the number that reframes everything. The cerebellum contains more than 50% of all the neurons in your entire central nervous system. More than half of your brain's processing cells packed into one compact structure. Its entire function is coordination, receiving real-time data from your joints, your inner ear, your eyes, and your motor cortex, and issuing constant microcorrections that keep every movement smooth, accurate, and controlled. When the cerebellum runs on full blood supply, you walk without thinking. You reach for a glass without looking. You turn a corner without calculating. When it runs on a chronically reduced supply, not stroke-level reduction, but a persistent, years-long mild shortage, those microcorrections slow down. They arrive a fraction of a second late. And that fraction of a second is exactly what produces the drift, the stumble, the moment of unexpected unsteadiness on flat ground. A 2019 study in Frontiers in Neurology confirmed that age-related reductions in posterior cerebral blood flow, the circulation feeding the cerebellum, correlate directly with measurable declines in postural stability and gait accuracy in adults over 60. This week, pay attention to whether your balance problems are worse in low light or when you close your eyes briefly. If they are, that is a strong signal that your cerebellum is compensating for reduced proprioceptive input using visual information. A classic sign of cerebellar underperformance, not leg weakness. So how does blood actually reach the cerebellum? Through a pathway so anatomically unusual that understanding it changes everything about how you approach this problem. Two arteries called the vertebral arteries supply blood to the back of your brain, including the cerebellum. What makes them unlike almost any other major artery in your body is where they travel. They do not run alongside your cervical spine. They run through it. Each cervical vertebra has a small opening in its lateral bony projection, called the transverse foramen. The vertebral artery passes through these openings one vertebra at a time, ascending from the base of the neck to the top, then curves over the first cervical vertebra, the atlas, and enters the skull. Inside, the right and left vertebral arteries merge into a single vessel called the basilar artery. The basilar artery feeds the cerebellum, the brainstem, and the occipital regions of the brain. Do you understand what this means structurally? The artery feeding your cerebellum is threaded through bone, and if there is chronic tension, stiffness, restricted mobility, or muscular spasm in those cervical vertebrae and the surrounding tissue, Those structures compress and distort the arterial pathway. The internal diameter of the vessel narrows, not dramatically, not enough to cause a stroke, but persistently, year after year. And the cerebellum spends those years running on a reduced fuel supply. Research in the journal Surgical and Radiologic Anatomy has documented measurable changes in vertebral artery diameter and flow velocity in association with cervical spine restriction and postural changes, confirming that this is not a theoretical mechanism. It is an anatomically verified one. Turn your head slowly to the right as far as comfortable, then to the left. Notice if one side is significantly more restricted or produces a sensation of pressure or mild dizziness. Asymmetric cervical rotation is one of the most reliable physical indicators of vertebral artery compression on one side. But before I show you what to do about it, I need to tell you about a patient whose case made this mechanism impossible to ignore. Robert was 67 when he came to see me. He had been drifting slightly to the right when he walked for 4 years. Not every step, but consistently enough that he had stopped walking in unfamiliar places alone. He had seen a neurologist who found no stroke, no tumor, no demyelinating disease. He had seen a physical therapist for 3 months. Leg strengthening, balance boards, resistance bands. His legs got stronger. The drift remained. He had been told that at his age, some balance decline was expected. He had accepted that. When I assessed his cervical spine, the restriction was immediately apparent. His right cervical rotation was significantly limited compared to his left. His cervicothoracic junction, the transition between the neck and upper back, was chronically locked. The muscles running along the right side of his cervical spine were in sustained contraction. On the right side, his vertebral artery was traveling through a compressed, distorted pathway for its entire course through the cervical spine. We began working on the mechanical restriction, the same technique I am about to show you. Within the first 2 weeks, his cervical rotation improved measurably. Within 6 weeks, his wife told me she had stopped watching him walk from behind, out of worry. The drift had resolved. His neurologist at his next follow-up noted improved gait stability and attributed it to the physical therapy that had ended 3 months earlier. One structural problem, one targeted correction. 4 years of drift is gone. Now, the most important thing I need to tell you before you begin working on your neck, because the most common approach people take makes the situation worse, not better. When people feel neck tension and decide to stretch it, they do what feels natural. Tilt the head forward, pull the ear toward the shoulder, rotate side to side with as much range as possible. All of that movement concentrates in the middle of the cervical spine, roughly the 5th and 6th vertebrae. That segment is already the most mobile part of the neck. It already bears the highest daily mechanical load. Adding more movement there does not help the vertebral arteries. It adds instability to a segment that is already overworked. The zones that actually need to move are different. The first is the cervicothoracic junction, the 6th and 7th cervical vertebrae, and the 1st and 2nd thoracic vertebrae at the base of the neck. This is where chronic restriction builds in adults who sit for prolonged periods, carry habitual forward posture, or have reduced upper body mobility. This is also where the visible bump at the base of the neck forms, what people often dismiss as a cosmetic issue. It is not cosmetic. It is a chronic mechanical block sitting directly over the vertebral artery pathway. The second critical zone is the very top of the cervical spine, the 1st and 2nd cervical vertebrae, the atlas and axis. This is where the vertebral arteries make their final bend before entering the skull. Restriction here has the most direct impact on cerebellar blood flow. Before beginning any neck work, locate the 7th cervical vertebra. Drop your chin slightly toward your chest and run a finger down the back of your neck to the base. The prominent bony knob you feel, the one that sticks out more than any other, is C7. That is your starting point for everything that follows. Here is the protocol. 2 components. First, release the mechanical restriction. Second, train the cerebellum directly. Both are necessary. Neither works as well alone. Exercise 1. Cervicothoracic junction mobilization. Place the pad of your index finger against the side of the spinous process of C7 nodidient, that prominent knob at the base of your neck. Begin turning your head slowly to the right. As you rotate, apply gentle pressure with your fingertip in the same direction. You are encouraging the vertebra to participate in the rotation it is naturally resisting. You are not forcing, you are guiding. You should feel a soft, elastic resistance under your fingertip at the end of the available movement. That slight spring is exactly right. Hold it there for 2 seconds. Return your head to center slowly, keeping your finger in place so the vertebra maintains its new position for a moment longer. This additional hold stretches the joint capsule and the inner spinous ligaments. That stretch is where the therapeutic benefit lives. Repeat for C7, then move one level lower to T1, then T2. 2 minutes total. Daily. Exercise 2. Cervical muscle lengthening. Place your palm flat on your collarbone on one side and press it gently downward. Slowly tilt your head away from that side and lift your chin slightly upward. You will feel a clean stretch along the front and side of the neck. That is the sternocleidomastoid, the long, powerful muscle running from behind your ear to your collarbone. When this muscle is chronically shortened, it pulls the head forward and compresses the cervical structures it runs alongside. Hold the stretch at the point of comfortable tension. Breathe normally. Return slowly. Repeat at a slightly more posterior angle to reach the lateral neck muscles. Switch sides. Finish with 2 minutes of firm self-massage along both sides of the posterior neck, fingertips kneading the muscle columns on either side of the spinous processes. Now the second block, cerebellar training. Exercise 1. Multi-rhythm coordination. Stand with feet shoulder-width apart. Begin rotating your hips in a slow, smooth circle. As your pelvis moves, let one leg begin a natural stepping motion in sync with the rotation. Now add your arms. Begin alternating drumming movements with both hands in their own separate rhythm, independent of your legs. 3 simultaneous movement patterns, each in its own timing. It will feel awkward at first. The rhythms will collapse into each other. That collision is exactly what is supposed to happen. That is the cerebellum working at the outer edge of its current capacity. Each day it gets fractionally smoother. When it eventually feels easy, new neural circuitry has been built. Exercise 2. Spotting turns. Choose a fixed point on a wall at eye level. Lock your gaze on it. Take 3 steps and make a full rotation. The moment you complete the turn, find that same point again immediately. Build speed gradually. Then reverse direction. This technique, used by professional dancers and figure skaters to spin without disorientation, trains the vestibular system to tolerate rotation without triggering dizziness. With consistent practice, the receptors in your inner ear adapt. The dizziness that currently follows a turn diminishes, then disappears. What to expect? In the first week, the neck work will produce increased mobility and often a mild warmth or sense of release in the cervical region. In week 2, most people notice a subtle improvement in morning steadiness. By week 4, the coordination training begins to feel less effortful. The movements that initially fell apart start to hold together. These are not placebo effects. They are the direct result of improved cerebellar perfusion combined with neuroplastic adaptation. I want to hear from you. Have you experienced unexplained drifting, stumbling on flat ground, or dizziness that your doctor has not been able to explain? How long has it been going on? And how old are you? Drop it in the comments. The age distribution of people watching this directly shapes what I cover next. And if you recognize Robert's story in your own, someone who was told their balance decline was just aging, I especially want to hear from you. You are not alone, and this is not inevitable. Now, if the brain fog, the memory lapses, and the mental slowness I described today sound familiar, and you want to understand what is specifically happening to your brain's blood supply after 60 beyond just balance, that is exactly what I cover in this video right here. Watch it next.